The purpose of this committee is to study national policy as it relates to small businesses that are struggling with affording health care. And you've done great work in Pennsylvania, and you've made small businesses the staple of your reform policies. So I was wondering if you could explain, to the degree you could extrapolate, how we might look at this from a national perspective, what you've done in Pennsylvania.
It's an excellent question. And can I say to the committee, when you talk about state plans, when Massachusetts pounds its chest and say, we have a state plan, and California and Pennsylvania are going down that road, it's a state-federal plan. Your plan, under my plan, the federal government would pay 33% of the costs. So it's not fair to say it's a state plan. It's somewhat similar to how we deal with Medicaid. We share the costs. And again, I don't know disrespect to Senator Obama, Senator Clinton, or Senator McCain, but I think one thing you should possibly examine is, do we promote states going down this road, and do we reserve to the federal government a couple of key things that the federal government can do that nobody else can do? Governor Pawlenty talked about bringing technology into the system, and we desperately need it, and it will save tens and tens and tens of billions of dollars a year across the nation. Well, right now, we're going down that road a little bit, but I don't believe we'll ever have a truly interoperable healthcare technology system without the federal government stepping up and at least putting matching dollars into the fray. And when I say matching dollars, not necessarily for the states, maybe, but also for the institutions, because they will benefit by it. We should have a card that you can take out of your wallet like a credit card, and that card should be, it should be the type of card that if I'm visiting friends in Seattle and for some reason I fall unconscious, while they're bringing me into the emergency room, somebody should take that card, stick it into a computer. It should give you my entire medical history, my blood type, what I'm allergic to, et cetera, and at the same time, read out tests. I may have had a EKG just the week before in my doctor's office in Philadelphia. That will save us so much money, and again, improve the delivery of healthcare services. How many episodes, they're called ADEs, when someone gets the wrong prescription and they get grievously sick because they get the wrong prescription. If you had that card that went from provider to provider, pharmacy to pharmacy, and you could stick it into a computer, we'd eliminate all ADEs. And so I think the federal government is the only vehicle who can upfront that money. But it's a particularly important role. Stop loss. If you had three corporate executives here, big business, medium business, small business, they would tell you that what kills them the most and drives up their premiums is the 1 or 2% of their employees who have significant illnesses, chronic care, heart disease, cancer, a brain tumor, etc. Well, stop loss, I thought it was the best idea that came out of Senator Kerry's campaign. The federal government pays 75% of the costs above the first $50,000. It's pay 75% of the cost. If the federal government did those two things, maybe we have a system where the state government provides the coverage, federal money matches it. Maybe we have a system that works there without, doing a massive program. Just two basic things. Now, there's a cost involved to this. You all know, and I know you're all smart enough to know this, and you've been here, that we're not going to get a program that will improve health care, constrain costs, give everybody access to health care without some upfront cost. But the option of doing nothing is the most costly of all. If we do nothing, those 75% increases in premiums in the last 7 years in Pennsylvania will continue. And I would submit to everyone that that is not an option. Right now, doing nothing is not an option for our healthcare system delivery problems.
Mr. Davis?
Thank you, Madam Chair. Thank you, Governor, for being here today. I come from the state of Tennessee, and you've probably followed TennCare down through the years.
Sure.
TennCare was such a good program that it went broke, and the current governor had to pretty much dismantle TennCare. How does your state's program parallel TennCare?
Well, it's different because we have a sliding scale of subsidies, number one. We make the employer and the employee contribute. That's crucially important. It's crucially important. And we believe we've done the actuarials and all of those things well enough that we've got revenue streams that will control the. It's always easy to do the first year of these programs. It's easy to do the first 3 or 4 years. What you should judge these programs by is what's the funding going to be? Are you going to be okay 10 to 15 years down the road? With actuaries and everybody else to try to make sure that adequate funding exists for the program down the road. It does no good to design a health care program and then have it go bust 7, 8 years later. It just increases people's frustration. So I think it's very important that what we study it, we do it well, and we do it practically. And it's not worth doing if we're going to try to do it on the cheap. And again, in the long run, I believe we'll save a tremendous amount of money, but it's not worth doing if we do it on the cheap. And putting technology into the medical system is a good example. There's going to be significant upfront costs, significant, and maybe it's the federal government, the state, and the providers that share the burden. But there will be tremendous cost savings down the road, tremendous cost savings down the road. So, but you're right. I mean, we've tried to plan. I gave the people who are working on prescription for Pennsylvania, I said, I want to know where we're going to be 15 years from now. And I think that's the crucial part of it.
If you look at healthcare right now, I think healthcare needs to be patient-centered. Patients need to own that, really not even government, not business owners. We need to have patient-centered health care.
No question.
And I think that's where we get off base sometimes when we're looking at health care. And if we could get it back down to the patient. I actually had a health care conference last week in my district, and I brought in U.S. Chamber of Commerce. I brought in National Federation of Independent Business. I brought in American College of Physicians. I brought in hospitals. I brought in large insurance companies. I brought in consumers. And I think it's vitally important that we have the stakeholders sit together and talk about the issues that are important and what we can afford, what we can't afford, what we need to do. One of the things that came out of the hearings last week in my district is we need more primary care physicians. There's so many physicians that are actually being trained, and then they can't afford to pay their lawns off by being a primary care physician. They have to be a brain surgeon or a cardiac surgeon.
It's an incredibly relevant point.